The next presenter will be Lindsey Reif, and she will be presenting on the point-of-care viral load testing among adolescents and young adults living with HIV in Haiti, a randomized controlled trial.
Hello, my name is Lindsey Reif, and on behalf of our team from JESCU, Cornell, and Columbia, I'll be presenting the results of our randomized control trial to evaluate point-of-care viral load testing among adolescents and young adults living with HIV in Haiti. This study was conducted at JESCU, which is the French acronym for the Haitian Group for the Study of Kaposi's Sarcoma and Opportunistic Infections. JESCU is the largest HIV clinic in the Caribbean. The HIV prevalence in Haiti ranges from less than 1% to just under 2% for adolescents and youth, with outcomes in this age group across the HIV care cascade worse than both children and adults. Our study objective was to evaluate an intervention to optimize one essential HIV service, viral load testing. An HIV RNA viral load is the biomarker which most effectively measures the continued effect of ART. It enables clinicians to assess the HIV treatment efficacy, and if a viral load is high, can trigger enhanced adherence counseling to improve adherence or a decision to change an ART regimen for those that may be on ineffective or failing treatments. It's an opportunity to assess ART adherence and can be a tool to act, to address barriers or reassess treatment options. Standard viral load testing requires high laboratory capacity using high throughput machines like the Abbott system. Clinics without this capacity must transport samples to a centralized laboratory and link results back to clinics, which can result in delayed or misplaced results. The Cepheid Gene Expert system can process a point-of-care test on site, operated by minimally trained laboratory staff, and can return results the same day. Our hypothesis was that the expert test can reduce logistical complexity, strengthen adherence counseling with same-day results, and lead to improved outcomes. Our study outcomes evaluate both the implementation and effect of point-of-care viral load testing compared to standard laboratory testing. Our primary outcome was the proportion of the test results returned to participants within 6 weeks of sample collection. The secondary outcome was the effect of point-of-care viral load testing on two outcomes, ART adherence and viral load 6 months from testing. Our eligibility criteria included all adolescents and young adults between the ages of 10 and 24 in care at JESCU who had been on ART for at least 6 months, also not pregnant or co-infected with TB or other comorbidities at enrollment. We measured ART adherence two ways. The first by self-report using a 3-item scale adapted from the AIDS Clinical Trials Group questionnaire. The items included 3 questions listed here. The first, on how many days in the last 7 did you miss an ART dose? Second, in the last 7 days, how good of a job did you do taking your ART? And lastly, in the last 7 days, how often did you take your ART in the way your doctor told you? We categorized responses into optimal versus suboptimal adherence and also developed an aggregate scale recoding each response with equal weighting to create a continuous score ranging from 0 to 100, with 100 representing the best possible adherence. Since self-report is known to be subject to bias, as an additional adherence measurement to provide a biomarker to compare with self-reported responses, we measured tenofovir diphosphate levels in the blood. PDF measurements have a half-life of approximately 17 days, which assesses cumulative ART adherence over the past several weeks and months to give an accurate drug level result. We measured TDF drug levels in the first 62 participants enrolled, 31 in each arm who were on TDF. The result is reported as F-moles per punch, which can be interpreted as the number of doses per week. Finally, viral load at month 6 was assessed as above or below 1,000. We also assessed change in viral load status between months 1 and 6. This is our full study schema. We enrolled 75 participants in each arm, the standard arm abbreviated as SOC and the point-of-care arm as POC. Both arms received a viral load test at month 1. The standard arm test results processed in the Abbott were returned to the participant with adherence counseling 1 month after testing at the next clinical visit. Point-of-care arm viral load test results processed in the Gene Expert or returned with adherence counseling the same day. Viral load tests were administered again for both arms at month 6 when ART adherence and viral load outcomes were assessed. Now to our results. This is a snapshot of the participant baseline characteristics. Median age was similar in both arms. A majority of participants acquired HIV through perinatal transmission, and at enrollment, just over half of participants in both arms had a viral load below 1,000. Overall, there were no significant differences in any clinical or demographic characteristics between the two arms at enrollment. Our primary outcome results describe the implementation steps of viral load testing by arm. For the month 1 test in red are our primary outcome results. A significantly greater proportion of participants in the point-of-care arm, 99%, received their test result compared to the standard arm, with 89% of participants receiving their result. These are self-reported ART adherence outcomes at month 6 using the continuous score. Now, in each question, the standard arm reported significantly better adherence, about 10 points higher than the intervention arm. So at first glance, we worried, is a point of care test somehow encouraging worse adherence, which is not what we had expected. So we looked at actual drug level results, the amount of TDF in the blood. We found drug levels were almost identical between arms, so actual adherence was not different despite a difference in self-report. So what wasn't adding up was how accurate self-report was between the randomized arms. To explore this further, we looked at the association between self-reported adherence and the viral load result at month 6. We found that reporting suboptimal adherence was strongly associated with a high viral load in the point of care arm, but this association was much weaker in the standard arm. This graph shows within each arm the odds of having a high viral load above 1,000 when reporting suboptimal adherence. Pink data points are the point of care arm and blue are the standard arm. In the point of care arm, the correlation of poor reported adherence and high viral load was very strong on each question, but in the standard arm, that correlation was much weaker, and in fact, for questions 2 and 3 and the composite, suboptimal ART adherence was not significantly associated with viral load. This told us that the point of care arm was reporting more accurately and honestly that they were not optimally adherent to their ART. Lastly, our viral load outcome results did not show a difference between the two arms at month 6. Just below 60% in each arm had a viral load lower than 1,000, and further, a majority of participants saw no change in their viral load. 44% in both arms were below 1,000 at month 1 and sustained this status at month 6, and about a quarter were above 1,000 and remained above 1,000. Our major conclusions from this study are that first, point-of-care testing was effectively integrated into a low-resource clinical setting. The clinic and the on-site laboratory successfully adopted a new protocol with a majority of participants receiving same-day results. We also saw the added benefit of more accurate self-report in the point-of-care arm, which could enable clinicians to both more quickly and accurately identify participants with a high viral load and determine the appropriate course of clinical action to provide enhanced adherence counseling or to change an ART regimen. This evidence together could support more frequent use of point-of-care viral load tests, particularly for patients at high risk for high viral load or at high risk for being lost before the next visit and never receiving the results at all. Thank you very much. I'd like to acknowledge our study team and all collaborators and look forward to taking any questions during the Q&A session. Thank you.